Thank you, Ms. Waldron. Ms. Nguyen.
Thank you, Mr. Chairman. First few questions regarding the governor's budget. Did your department request for the governor or even ask the governor to consider, restoring MediCal provider rates to pre-AB 97 at all this year?
Maybe I can play the new kid card since I started on February 9th. I think that when administrations work internally through the budget development process, we do a lot of different things to prepare for the governor's both January budget as well as the May budget. All of the items that we develop internally to help inform the overall budget that's released are not necessarily either documents or policies that we would otherwise share. So what is released by the governor on January 10th is what we, as an administration, would set forth as the budget.
Do you feel, though, today that the provider rates is accurate enough for what we are today? I mean, as the director, I want to hear this, because I want to know if you feel that we're good, we're okay, pre-97, we're good, we're still fine, legislator, don't do anything about it, or do you feel that way we should actually step back and take a deep breath and start reevaluating?
I think it's a fair question to ask. I think that by and large, with the authority that I have as a director and that the department has as it pertains to the rate reductions, to the extent that we have received data in the past, either from specific providers or from legislators or to Mr. Wood's point, in a specific geographic area where we receive information that says, hey, department, you have a problem in this specific area. We have looked, we have analyzed, and if necessary, we have made changes to that. And so I would never say that it's perfect or that it's great, because we can always do better. But I think that to the fact that we are very carefully balancing both access and the overall economic impact to the state budget generally, is we are trying very hard to make sure that we do both, that we protect access, we provide coverage at the right place and time, and that we're also mindful of the fiscal import of any change in the program and what that means to the overall state budget, because there's obviously other priorities that both the legislature and the governor also want to fund. And so I take very seriously, what my charge is to make sure that we take your issues, and if there's specific areas or provider classifications that need our further digging, then we will certainly do that.
And I appreciate being able to try to balance access with the state budget. But we also, though, need to look at is we can spend $1 today, but then end up in the back end, we're going to spend $1,000 for someone to go to the hospital. I mean, we can't just stop at the state budget. We also have to look at the consequences of those rates. And so, what I would encourage is to maybe, if there is a data ready, if there isn't, maybe help me find it and maybe provide to my office, is how much are we spending on the back end if a child isn't getting a dental appointment? How much are we spending if a child or an adult are not getting an eye exam? And I'll tell you, in my district, because, formerly being a county supervisor, there's limit to what we can do. So instead of going to the state and start begging, I just say, you know what, we don't have access, we're going to provide it. And so we host a health expo that has 3,000 people plus annually who goes. Mainly has to do with dental and vision. I mean, it broke my heart when I saw a child at, I think, 5 or 6 in the morning, and I didn't know she was standing in line. Her teeth was in pain. I pulled her out of the line and brought her straight to the facility to get her a dental exam immediately. And in my district, a lot of areas are 80-90% of the children are on MediCal. It's not just access to being able to have providers available, but it also is economically. Parents are working, transportation, all that. But even when you talked about you're looking at potentially finding some kind of incentive to increase the provider participation. It's the rates. That's your incentive. You can give a provider $1,000 more just to sign up for the program, and in 3 months they'll get off of that program, because their business will be so inundated with all these patients that they can't provide, and they will go bankrupt. Nobody goes into business in the state of California or anybody to break even. It is unfair to these dentists. It is unfair to these providers. And so if you want an incentive, let's increase that rates. Because these children, I mean, I can go on with healthy families. I was a big supporter of healthy families. I think we did a big mistake, but I can respect the decision of the legislator and just respectfully disagree. Because when we did that, you forced millions of children into a system of MediCal that can't even sustain the current system of adults. Now you've pushed the children over in that direction as well. And so, when you talked about, having to look at each of these item by items, please do not just look at, again, I go back to this, it's not just about rural versus urban. Even in the urban area, we can't have access. We are now going, not only do I do my expo, I've partnered with nonprofits and providers. We go into the school district ourselves, and we start targeting certain school districts and certain numbers of children for the month or for the week to try to bring dentists and eye doctors, optometrists into the school and get permission from the parents and et cetera. That's where, because most children, especially under 5 or young children, not just under 5, they don't even know what a toothache is. They probably think that's normal, and they should not be in that situation. Every child in this state should not be in that pain. And so, when you go forward looking at these, is to help me at least understand is a study of what happens if we don't get a child a dental exam. What happens if we don't get a child to the eye doctor? Because most children who can't see sits in the back of the class. And those in the back of the class are the one who gets the worst grades. They're the one who's going to be destructive to the classroom. They're the one who's going to end up not doing, we'll actually end up, if they end up in jail, we as a society pays more for it. And so, as you go forward, I really hope that if you talk about incentive, you mentioned from 2009 to 2014, we increased 2,000 new providers for DentaCal. That's in 5 years, only 2,000. But yet we have 12 million people in the system for 15,000 dentists. I don't know, is that enough? Tell me. Give me the data to tell me that's enough. That if every one of those individuals, the 12 million, decide that in the next month I have to go to the dentist, will the 15,000 providers be able to care for all 12 million people? Thank you.
Thank you.
Thank you, Ms. Nguyen. Dr. Ed.
Thank you very much, Mr. Chair. First of all, Ms. Kent, I want to commend you for your commitment to public service in state government, at MediCal as well, and congratulate you on your new appointment. And I appreciate the fact that you're here this morning. And also, Ms. Cantwell, every time I've heard you in committee, you've had some very good and excellent presentations, and I appreciate the information given to us. I have maybe a question, and obviously some statements. And I was very impressed with Ms. Cantwell's presentation about obviously how we look at fee-for-service compared to managed care. 80% of managed care now is the patient population, and how the plans, through the Department of Managed Health Care are required to give you all the data. I understand they have to be actuarially sound. I understand that you have networks, provider networks, et cetera. But I also understand and know that when you deal with fee-for-service, for example, and this is going to eventually lead to a question, that CMS is going to require certain things. For example, payments are consistent with efficiency, economy, and quality of care and are sufficient to enlist each providers so that the care and services are available under the plan at least to the extent that such care and services are available to the general population in a geographical area. And keeping in mind and understanding that only 20% of it is fee-for-service, that's what you need to abide by. The remainder of the population needs to abide by Department of Managed Health Care with regard to how it sees its population. And there they have to contractually require MediCal managed care plans to abide by the time and distance standards in the Knox-Keene Act. The Knox-Keene Act is a body of law regulating health plans and requires primary care physicians to be no more than 15 miles or 30 minutes from the place of residence or work of a member unless the member chooses a different provider. The MediCal standard is a 10 miles from the member's residence unless the plan has a DHCS-approved alternative, etc. So obviously there are some statutory requirements that patients within the MediCal population have to have access to care within the general population. Here is my question for you. Does the MediCal patient population have the same access that someone who has insurance through a company in Silicon Valley like Google? Yes or no?
So I can tell you that...
It's just a yes or no answer.
Yes.
I don't think so. I disagree. So you're telling me that somebody in the Central Valley is going to make a call and get to see a primary care provider and a specialist and all the services similar to somebody who has the same health insurance as somebody who works for Google, and the same networks, the same providers, the same specialists, the same hospitals?
They have the ability through their managed health care plan to have primary care physicians.
They have the ability, but do they have
specialists? Not the same networks necessarily, not the same hospitals, but to the extent that we are providing care through our managed care plans and that these plans are held to the standards that Knox-Keene sets forth.
They're held to the standards. I get it.
They are receiving that care.
But
yes.
Is somebody in South Central Los Angeles, in Watts, in Compton, will have the exact same care as somebody who works for Google? I don't think so. And I think there's a huge disparity. And so the lens that I'm going to be looking at this through is comparing that population with the population that has the greatest needs. And my biggest concern is those individuals that are under 138% of poverty level that should have that exact same access. Now, I understand that we're talking about rates right now. And rates, yes, are important. And I think rates, what I've heard the other members, are going to drive, hopefully, knock on wood, providers to be able to take and see more patients. There's a much bigger problem. We have capacity issues. We have workforce issues. We have providers that aren't going to go to those areas. Yes. And I believe that this bill that we're both going to be running together, myself and the chair of the Assembly Health, at least has to start that conversation of how we're going to get that same care and that same access to that vulnerable population. But maybe what we should do, and then I might have a second question in a little bit, is maybe what we should do is start looking at how do we creatively incentivize providers to go to those particular areas. And I'm going to draw an example. The governor's done a great job, and I believe he's taken his fiduciary responsibility very, very serious. But I don't think he's taken as serious when it comes to health care, especially with the 10% reduction cuts and restoration of it and the clawbacks, which I believe is just egregious. He's done an incredible job with regards to local control funding and education. Why don't we start having the discussion and the conversation, the policy discussion, in that light as well? And looking at it, and not only, because in local control funding, schools that have English learners, that have free and reduced lunch, that have, foster care, are going to get more money. Why don't we start looking at the conversation that those vulnerable communities that have the greatest needs, maybe we pay above Medicare rate. Maybe we should start having that conversation. Why don't we do something very unique where in those particular areas some of that money goes for residency programs to get primary care docs to go to work in the most vulnerable populations. I think we have to look at changing the discussion so that we get care in the absolute greatest needs in the area. I believe that I don't know who made the comment with regard to the waiver. So I guess the question I have for the administration, when Assemblymember Bont and I are going to be working on the waiver bill as well, should we be looking to the federal government on how the waiver can address access, physicians, specialists, and maybe is that a priority for the administration? Is that a priority for you?
Absolutely, yes. That is our waiver. Our draft application will be released in the next couple of weeks, and hopefully you'll like what you see in there, because a lot of what you're talking about is what we've included in our waiver through the various stakeholder groups that we've been holding over the last several months. Workforce development specifically is a category that we're asking for additional flexibilities and support in, including things like expanding residency slots at primary care clinics in particularly underserved areas as a way to hope to train more, but also hopefully keep providers in those underserved communities. That is one of the elements that we're proposing. We're also proposing various sort of shared savings incentive structures that would encourage providers and plans and county organizations to come together to work as essentially like an accountable community or accountable organization to share the responsibility and the potential benefits of working together to actually improve the quality of life and quality of health for folks, including those things. I mean, right, we're the Department of Healthcare Services. We're really focused on healthcare delivery, but what we know is for populations, the impact to their quality of life and quality of health, a lot of it is actually outside of the healthcare delivery system. And so we're also proposing that we have the flexibility to allow counties and plans and providers to come together in whole person care pilots that would actually test and demonstrate that spending Medicaid funding on things that are not specifically healthcare delivery, like increased access to housing and supportive services, would actually result in decreased healthcare costs. And so those are all things we're including in the waiver, and that we hope we can work with all of you to convince CMS is the right direction to go for Medicaid, because it is, at the end of the day, will save the federal government money as well if we increase access to those things and reduce the downstream costs of unnecessary hospitalizations and emergency room visits.
Thank you very much. Assemblymember Bont is gone. I will be chairing at this point. I believe Ms. Assemblymember Chow had a question and or comment.
Thank you, Mr. Chair. It's Assemblymember Chu. But first of all, I want to just start by saying that I represent the city of San Francisco that has been on the record of opposing the rate reductions that we're talking about based on resolutions that I had authored when I was on the Board of Supervisors. I want to thank our chairs for really kickstarting this important conversation today. My first question is based on a figure that your department had presented in your briefing paper, saying that total fund savings from AB 97 reductions would be about $275 million in the general fund. You know that there has been a discussion of policymakers about a proposed increase by the administration for one drug, a $300 million increase this year, one drug that would help provide about 3,000 patients with care with regards to hepatitis C. So comparing the rate reductions, $275 million in the general fund versus $300 million proposed for this one very high-cost specialty drug, $300 million, how does the administration take into account those sorts of decisions? All of us want to provide care to all of those patients, 3,000 hepatitis C patients, likely 50,000 patients that are being denied care with regards to MediCal. How do you think about making these choices?
Do you want me?
So this is why sometimes we have these jobs, right? They're really hard and they're very complicated. So for the hepatitis C, I can say that, speaking from a MediCal perspective, the day that the FDA approves a drug, it is immediately a drug that we are required to pay for under a medical necessity requirement. So costs not being under consideration at all. The day that a hepatitis C drug was approved by the FDA and a physician prescribed it for a patient, we were, if everything else was appropriate and medically necessary for that particular patient and that particular drug, we paid for it. And so in some cases, we don't have a choice in what we have to provide. And so if an individual is prescribed a certain set of therapies, and it could be hepatitis C, it could also be a chemotherapy drug, it could be a very expensive bio drug for a genetic condition, we are held to a federal requirement as well as legal requirements, and quite frankly just good practice and running a good program of taking care of people, we provide those things regardless, in some cases, of what the cost is. Do we try and negotiate with those pharmaceutical manufacturers? Absolutely. Do we try to collect supplemental rebates? Absolutely. That amount of money in the budget is not only for MediCal, but it is also inclusive of the other state programs in which they are also held to the same kind of standards that we are. So corrections, to the extent that there are individuals in the correction system with hepatitis C meeting the treatment standards, they are having to provide those pharmaceuticals to those individuals, individuals in our DDS facilities, other places in the state, CalPERS, other state purchasers. That $300 million, believe was indicated for the broader state purchasers of who we are buying drugs for, not just on the MediCal side, but also in other state programs.
You covered what I was going to say.
I appreciate that answer. As I think you know, obviously the 3,000 or 3,500 patients, the $300 million would help to serve, really represents a tip of the iceberg of the 750,000 individuals in California that may need some help when it comes to hepatitis C. So I know this is an ongoing conversation. I think the other thing I would say is I think we as a state and certainly as a healthcare system will have to grapple with some of these very high-cost drugs and look forward to having more conversations about that.
We are looking forward to having that conversation with the legislature as well.
Great. My second question is around immigrant populations. I certainly represent a district, as I think many of us do, with extremely high immigrant populations that do not have access to health care. And certainly with the failure of federal comprehensive immigration reform, we have, it's estimated, about 1 million individuals who may not have documentation, who do not have any insurance. Could I ask what sort of plans does the administration have around addressing these populations, particularly given that we know that the cost of inaction is likely far higher than any budget to provide access to care?
Sure. So I think a couple of things. One is with respect to the population that, from the president's immigration order that would have, a deferred action status, we're looking at what potential impact that would have in terms of folks coming into our MediCal program. I think as we've discussed before, there are current processes by which individuals can enroll in the Medicaid program regardless of certain immigration statuses, and that will continue for that population. The other thing that we do is, although we're the Medicaid program, we also make sure that there is a safety net system for those who are not either have full coverage or have any coverage at all, whether it's an immigrant population or another uninsured population. And our safety net system that we help support really provides the vast majority of the care to that population. And we are working with them through, again, waiver initiatives to refocus that away from, emergency and a hospital-based care to provide, particularly our county partners who have public hospital systems, the flexibility to instead have the Medicaid money that is intended for the uninsured be used in a way that actually provides better access to care, particularly primary care and other ambulatory care. And we are working with the federal government to have that ability to do that because the funding that we get is typically related to hospital services. And we want to recast that and say, let's give the providers who are providing this care the ability and the flexibility to better coordinate that care and have care be provided in a primary care setting, which at the end of the day results in better quality of care for those individuals as well as lower costs. And so we are seeking that, and we think we have a very good case to make that would actually demonstrate the importance of providing primary care and ambulatory care to these populations.
Great, thank you. And then just one final comment. I want to join Dr. Wood in his questions around Dentacare. I know certainly from your perspective, the number of providers enrolled and utilization rates appear to be going up, but from any other statistic, it seems like our kids are not getting the dentistry that they need. And I know that the state auditor released a report today. I think later on in the presentation, we'd love to just hear your reaction to that report. Because certainly in San Francisco and I think around the state, many localities are trying to figure out how to backfill the lack of access, and we certainly need help. Thank you.
Thank you. Any other questions from any other member? One more? Yes.
Yeah, and I'll be brief. You mentioned earlier the CAPS, you use CAPS as a way for evaluating. Can you explain why the relatively low marks for our managed care program in California? We typically get 1 to 2 stars, and other states get 4 and 5. So can you explain why our managed care program in California gets such low marks?
I mean, Mary can also, while she's shuffling and looking for some of the data that we do, I think that's a great question. You know, I obviously have worked with the plans, you know, in prior jobs as well. I think that the population sometimes, when you are trying to go out to survey, is incredibly, sometimes it's just difficult, right? MediCal has a far more transitory population. People move and they change county service areas, and so a lot of times even just getting someone to answer either a phone call or respond to a piece of mail is also difficult. So I sometimes think that the scores are a result of just having difficulty in actually receiving enough individuals to actually respond and have it show some other kind of you know, quality that we think is actually there. I think the other thing is that the populations that MediCal has typically been seeing in recent years as we've transitioned seniors and persons with disabilities into the program was certainly a challenge, right, from the standpoint of these were individuals that were previously unmanaged, meaning they were taking care of their own care in a fee-for-service system. And so I think that a lot of the plans at first had some initial struggles to get those individuals into a medical home, and then you started to see where the organized and the coordinated care started to have a positive impact. And so, again, I would draw the study that the Blue Shield Foundation put out last month as a really kind of, it's not to say that we have solved the problem, but that we are moving the needle towards a more positive enrollment and satisfaction with our beneficiaries through having these plans. So I think that we have more work to do, but I think that we are actually going in the right direction.
And just one final follow-up, is that through the chair? You mentioned, I think it was Mary who mentioned this, incentives in the waiver for Delta Dental. That's what I heard.
Incentives for dental providers.
For dental providers. Okay,
Yes.
Then can you explain how that's working and how that filters out? I thought I heard Delta.
No,
I thought I
that's
heard
okay.
during the intermediary. So
So it's part of the proposal of the waiver renewal, so it's not something that's happening yet. But what we're doing is working with stakeholders to determine what would that actually look like. But the couple of areas you'll see in our waiver proposal that will come out in the next couple of weeks that will then be submitted to the federal government at the end of the month are particularly how do we incentivize the provision of preventive dental services, how do we target funding for dental services in particularly underserved areas. Those are the things we're looking at, but we certainly welcome input on what are the best ways to think about using the waiver as an opportunity to help increase access to care and utilization of dental services.
okay, thank you.